This lecture is going to focus on drugs that are used for thyroid disorders. The two main disorders are hypothyroidism and hyperthyroidism. So too low, too high, and what we need to do for there. Okay, so this first slide just looks at what are the actions of thyroid medications. And basically, the actions of the thyroid medication are to do what, if it's for hypothyroid medication, it's to do what the thyroid does, to make the thyroid work, to do the things the thyroid should do. If it's hyper, then it is going to control the thyroid. It's going to kind of tell that thyroid, don't work so hard, just work less hard. Don't put out so much. So the thyroid has three principal actions: stimulation of energy use. So it elevates our BMR. It gets us going. It does those types of things. Stimulation of the heart. So increase the rate and the force of the contraction of the heart. So if you need to get it going faster and working harder because you're working out, the thyroid's the one that tells the heart, like, hey, hello, not getting enough here, let's go. And then it's promotion of growth and development. So it's essential for the development of the brain and the nervous system, and to keep the brain and the nervous system running. So we don't just get rid of that, okay? So remember these actions as you start to think about hypothyroidism and hyperthyroidism, because that's going to tell you the adverse effects from the medication. So if you're giving something that's going to cause the thyroid to work because it's not working as well and they're hypothyroid, your adverse effects are going to be the bad part of this. It may make their BMR go too high. It may make their heart rate go too high. Those types of things. And if you're giving something to slow it down, you may see that their BMR drops. You may see that their heart rate drops. Those types of things. So as you're going through these and you're thinking about those adverse effects, that's just something to keep in your head. So there are several thyroid function tests that you may be dealing with. For dealing with the medications and all, there's not much that you have to know, other than usually we just use the serum TSH, primarily for screening and diagnosis and for monitoring replacement therapy. So if you have a patient who's receiving a medication for the thyroid, like levothyroxine, you may need to be seeing what a TSH is. And if they've been in there for a few days and you don't have one, and there's not one in the history, that would be something that you would say to your healthcare provider, like, hey, can we just order one and see where we are, see how this medication's working. You may also see a serum T4 and a serum T3. Don't get bogged down in your studying about what these do. It's just letting you kind of know if you see these on your lab results, that's what they're looking at. So hypo versus hyper. Too slow versus too fast. It's important for you to know both because meds will change what you see. Hypo is kind of where everything's slowed down. This is the patient who's going to gain a lot of weight because that thyroid's not regulating their BMR. This is the patient that's going to have very little energy because their heart rate's slow and they're always cold, their temperature's down. They may come into you and say they feel foggy when they're thinking. They just can't think straight. Their brain's just not functioning the way it should. That's what you're going to see. Hyper, which is it's too fast, the biggest thing that you're going to see is Graves' disease. So going back to patho, remember kind of what Graves' disease does, and it's that speeding up of everything. So the heart rate's fast. They're hot. They have all this energy. They can't sit still. They can't get enough food. And then on the bad side of hyperthyroidism is thyroid storm, and that's kind of where the thyroid just goes crazy, and they get this really high temperature, 106, and we have to do something. A lot of times, if thyroid storm happens not because of medication, but because of the patient, they're going to have a thyroidectomy, and we're just going to pull it out, and we'll just give you meds and type of thing. So, kind of go back to patho and look at those. Thyroid hormone replacement. So if you're low, that low person, that person who's gained weight, they're always cold, they're sluggish, they're not moving as fast, you're going to see them probably get levothyroxine. Okay? And I say probably because there's true levothyroxine, okay, which you will give the patient, which is just the hormone itself. And then there's the generic version or the drug version, which is Synthroid. So you're never going to see a patient taking both, or you shouldn't. And then the other thing to remember is if they're on levothyroxine when they come in the hospital can't say, well, let's give you Synthroid because it's cheaper and we like it and it works the same. These are two medications that do not, they are the same thing. One's a generic, one's a, just the brand name or whatever. But they, for some reason on patients who respond to Levo probably do better on Levo than patients who respond to Synthroid. But Levo's the one that we use out there as the drug. Synthroid's going to do the same thing that Levo does. It's just a different version of it. So it's a synthetic preparation of thyroxine. So it does what you take it, it does what your thyroid should do. It's indicated for all forms of hypothyroidism. If administered in the right dose, you shouldn't see any adverse effects. So if your patient is getting the right amount that the patient needs, you shouldn't see any of those things. They shouldn't be talking about a racing heart. They shouldn't be talking about trouble being hot and that because you're giving them enough. If you're not giving them enough, then they're going to come, or if you're giving them too much, if you're giving them too much, they're going to have those complaints. Those are going to be your adverse effects. So you would back off on the dose. If it's not working, so you still have the sluggishness and all that, then you know you have to go up. There are some drug interactions that you need to worry about. The biggest one is that it accelerates the degradation of vitamin K. So we take vitamin K so that our blood will clot. Okay, or need vitamin K so our blood will clot and those types of things. Well, by giving you levothyroxine for your thyroid, it's going to kind of speed that up. So you may have patients with bleeding issues then. Okay, and then the question, can you interchange preparations of levothyroxine? Usually not. Usually if a patient responds to one, for some reason they're not going to respond to the other as well. So you cannot have a patient on levothyroxine and again go, oh, well, we don't have that up here this week. Let's just give you some Synthroid to get you through. And not going to help. You can change it, but you're going to have to start the process of learning what they're doing and how they're doing and what works for them and how much all over again. Drugs for hyper, so if it's going too fast, you have the thionamides, the methimazole, okay, which inhibits thyroid hormone synthesis. So it tells the thyroid and the, it actually tells the pituitary, not the thyroid, but it tells the pituitary, you don't need to make any more of that thyroid hormone synthesis. We don't need the thyroid working. It's working too much. It's typically used to treat patients with Graves' disease. You may see it given if your patient is going to have thyroid surgery. They may give this to kind of shut down that thyroid so that during surgery they know that they're not going to cause any problems. The biggest adverse effect is agranulocytosis. Again, this is one that if you're giving it in the right dose, they shouldn't have too many adverse effects with it. Another one that you will hear about is the radioactive iodine. And again, it's used mainly for Graves' disease. Again, does kind of the same thing, inhibits the thyroid. Not many side effects, other than people don't like the word radioactive, because they think radiation, and there is some of that effect that we got to think of. The non-radioactive iodine solution that you may hear about sometimes, I haven't heard about it much. I heard it when I was in school, and it was big when I was in school, but as I've gone through my nursing career and gotten further into this, I haven't heard much about Lugol's solution, but you may have a patient who's still using Lugol's solution, so just kind of keep that in your head, not that you need to know much about it. So nursing implications. What do I do if I have a patient on this? The big thing is levothyroxine or Synthroid, whichever one. These are the big ones you're going to see because you see more hypo than you do hyper. Is to remember that your patient needs to take that on an empty stomach and usually 30 to 60 minutes before they eat. breakfast, so they're going to take it in the morning. So if you have a patient who's on this, one of the things you need to be looking at in your chart is, oh, when can I get in there and give them this before they order breakfast. Most of your hospitals nowadays are going to what we call breakfast or food on demand. So they call down to the kitchen, they say this is what I want for breakfast. As long as it's on the menu, they get it, and they get it when they want it. You know, it used to be in the older days when I started nursing, food trays all came up at 9 a.m. Lunch trays all came up at 1. Dinner trays all came up at 5. And so you could plan, okay, I know breakfast is going to be here at 9. This person's got levo, this person's got insulin, this person has this, and you could catch them when you knew food was about to be there. Now, the patients get to call down and kind of choose when they want to eat. So again, it's going to be education on your part to tell that patient, look, I need to give you this medicine before you get breakfast. So if you're ordering and you like to eat at 8, let me know so I can get in here at 7 and give you this levothyroxine. The methionazole, the one that's for the hyper, to slow it down. The big thing is it does have some effects on the brain development and nervous system development. So if your patient's pregnant, especially in the first trimester, you want to try to avoid using that. The problem is that the patient's on this for a while and doesn't know they're pregnant. So again, educating that patient who's on it that, hey, you really need to use birth control. If you want to get pregnant, let us know. We can work with you with other medications. And then radioactive iodine and the non-radioactive, there's not much for nursing implications other than just kind of knowing if a patient's on it and how much and what you need to do.